Another research study was done. Again, it was done retrospectively. There were 778 lumbar cases presented. Intervention, 10 to 25 sessions of these. And I'll get into some of the details on the sessions. It's similar to physical therapy in that it requires approximately 20 sessions, and that's the recommendation of it. And the outcome measures on this was that there's visual analog scale over time. There was improvements in mobility, improvements in function. Another study showed on axial decompression that there was a 65% improvement in mobility, 71% reduction in pain, and 75% improvement in activity. More retrospective research was done. This was to determine if the pre and post MRIs after doing the non-surgical decompression was significant. 20 cases, 20 sessions, as I suggested earlier. There were changes on the MRI pre and post treatment. And it shows that in 29% there was a 25 to 50% reduction, 43% there was a 50-100% reduction. This just showed the improvement on the visual analog scale, that there was a reduction from 5.8 to 0.8 on the visual analog scale post-decompression. This is on the activities of daily living. Basically, it just shows that people were able to improve in sitting, standing, walking, stair climbing. Overall, their activities of daily living had improved with this decompression. There's presently a lot of research going on in regards to this particular kind of treatment. It is different than some. There's Sony Research Foundation in Baltimore is doing it. There are double-blinded studies being done just to look at the post and pre-MIs to see the changes so they can substantiate how well this works or how well it doesn't work. There's some more active research going on at the Greater Baltimore Medical Center, randomized controlled studies. One of the companies that produces it, this SpineMED, is the one I use in the office. And I did a lot of research before I decided to take this approach. They're also doing some research in it as well. A lot of this right now is retrospective clinical studies that have been using to validate the treatment, and it works extremely well for some. This is a patient I saw in the office. She is a 30-year-old female. She actually is a law enforcement officer, wears a gun belt around most of the day and a vest. She had pain radiating down her leg. Initial onset was a year previously. She was actually referred to me by an orthopedic surgeon because she didn't want surgery. She was on Motrin, on Darvocet, previously Flexeril. She had tried chiropractic and she had tried physical therapy, which included McKenzie exercises. And the findings on her physical exam was range of motion, was decrease in the lumbar spine, pain, decrease in rotation and side bending. Her strength was decreased. Faber's test was positive. Reflexes were normal. Straight leg raising test was negative. Diagnostic study, she had AP and lateral films done. There was a disc height loss at L4, L5. But what I thought was particularly impressive was she had a large disc herniation that measured 9 millimeters in the AP direction by 10 broad. It was effacing the ventrothecal sac, impressing upon the central canal. It produced moderate canal stenosis. She also had a broad disc bulge and a radial tear at L5S1, some effacement of the ventrothecal sac there as well. This is a picture showing the L4, L5 disc as well as the L5S1 disc, and of course we have our infamous dark black disc compared to those that are hydrated much better. This is indicative, remember, of losing the nutrients, and not only just the nutrients in the water, because when I was trained, we talked about the disc just lost most of its water and it's lost its hydration. Turns out it's lost much more than that. It's lost its hydration, it's lost the nutrients, the glucose, the keratin, and the chondroitin. Basically, I started her on a treatment. By the 6th visit, her pain was reduced from a 4 to 1. By the 10th visit, 1 to a 0. By the 20th visit, it had stabilized to a 1. She did 4 more visits, and basically, she had a home exercise program because I believe that anytime you do any kind of interventional treatment, exercises and a home program are keys to maintaining it. I also would recommend some distraction. So she had already an inversion table at home that she said really helped her, and so I suggested that she continue to use it to help facilitate the gains that she had made. She's an unusual case in that her MRI that she had originally gotten was from a year previous, so from a insurance standpoint, it seemed viable to try to get another MRI so I could actually see what was happening, because I just really wanted to know and I was curious. So post-SpineMED findings on her physical exam showed that she had full range of motion in her lumbar spine, her strength was fine, Fabers was normal, reflexes and straight leg orientations were normal as previously. This actually is similar to the other improvement of the disc that I showed you. Actually, this is the disc that was herniated. It was actually protruding out, and I'll show you what the radiologists, what they said about the disc shortly, but this is how it looked. And the post-SpineMED findings on the MRI showed that that disc that was herniated 9 millimeters was now down to 1 to 2. In the AP dimension that was 10 is now down to 9. And there was only mild narrowing of the thecal sac. The diffuse disc bulge at L5S1. And I did send her back to the same place to get her MRI. The diffuse disc bulge had improved. The tear that was presently there in the annulus, there was no radial tear at all, and there was no thecal sac effacement, which I thought were some nice improvements and were consistent with the complaints that she initially had and the improvements that showed on physical exam. Conclusions, basically, this is just another opportunity or way to keep somebody from having surgery. I use it as part of physical therapy. I use it as part of the treatment with injections. I personally don't do injections, but I will attempt it sometime. I'll start some people with this particular treatment and they're just too sore to tolerate it. I'll refer them to the pain management folks in my area. They'll do epidurals, they'll do facets, they'll calm it down, they'll come back, and we'll start treating the disc itself. I'm pretty much an inclusive person. Whatever works, I'd like to try, whether it's therapy, injections, this decompression, and of course, as a last resort, surgery. But after speaking to a number of neurosurgeons and orthopedic surgeons, when you think about surgery, and let's think simply about a discectomy. When you do a discectomy, basically if there's a herniation, you take out that portion of the disc. When you take out that portion of a disc and you take it off the spinal cord or the nerve itself, you decrease the volume of the disc. With the decrease of the volume, you create potential problems in the future of neuroforaminal stenosis or even facet syndrome. So you solve one problem, but you potentially create others. I asked one neurosurgeon in New York, and I said, why don't you do a neuroforaminotomy, which means increase the size of the foramen when you do the discectomy? And he said, I'm old school and I do that, but the younger guys want to get them in and out, and they don't do that because eventually the person will probably need another surgery because of the loss of the volume of the disc. So some of the reasons that are rectified with the surgery create other problems. So again, as a last resort, if you have to do it, it needs to be done. But know that each surgery actually creates other issues in and of themselves. And I'm not saying that there's no successful back surgeries. There are some. However, as it was mentioned earlier in some of the lectures, a year down the road, 2 years down the road, 3 years down the road, these people come back, partially from the fact that certain things happen during surgery, and also some of that, again, is about the disc being predisposed to problems because of some of the hereditary factors that I mentioned earlier.